let's move on to a few more HER2 topics before we get to tyrosine kinase inhibitors in HER2. The first one is there was a trial that was presented at ASCO, PHEREXA. So Sunil, I think you actually are the discussant of PHEREXA at this year's meeting. So can you comment on that?
PHEREXA, I think, is an important study. It was done sort of pre-integration of T-DM1 in the context of metastatic breast cancer. So these were patients who had prior metastatic trastuzumab for advanced breast cancer, and then were randomized to either capecitabine trastuzumab or capecitabine trastuzumab plus pertuzumab. Initially a phase 2 trial that was then expanded to a phase 3 setting. And what it showed was that there was a difference in PFS, however, was not statistically significant. It went from 9 months to 11 months. Now, 9 months for capecitabine trastuzumab is pretty good, much better than what we've seen traditionally. And then the overall survival, there was an 8-month difference. But because it was a hierarchical statistical design, because the p-value was not significant for PFS, they can't really look at the p-value for overall survival. So where does that leave us? And basically, my discussion is going to be that this is a negative trial. It was an underpowered study. Yes, pertuzumab does appear to have activity in this trastuzumab pre-treated patient population. We have seen that. However, we cannot justify the use of this based on this negative trial, and especially when we have other options like T-DM1 now for those patients who have had trastuzumab. So, would this study have been meaningful maybe a couple of years ago because we had some patients who never got a chance to receive pertuzumab in the first line? Sure, but now where majority of patients would have gotten pertuzumab, now that we have T-DM1 in the second line, really the clinical meaningfulness of this study is much limited as a result, and at the end of the day, a negative trial.
I think, though, that I completely agree with everything you said. From a practical standpoint, for patients who have not had pertuzumab, to me, the 8-month improvement in survival, which was a little hampered by the fact that you couldn't put a p-value on it, still is very impressive and kind of shows what we already know about pertuzumab from the frontline Cleopatra, and I think justifies the use of getting at least one, I shouldn't say at least, but one line of pertuzumab in the metastatic setting.
Yeah.
Because, I hope the trial's not used to say that, gee, you have to get it in the front line or you don't get it at all, basically, because I don't agree with that from the interpretation of that
the challenge there, Joyce, is that, it's hard to, why did the PFS not improve to the same magnitude? Because if you look at the hazard ratios, the hazard ratio for Cleopatra is like 0.68 for PFS, 0.68 for overall survival, very consistent. Here, the hazard ratio was around 0.68 for overall survival, but there was the hazard ratio was around 0.8 for PFS. So it didn't quite, I think if we had seen the same magnitude of effect in PFS, and it was a negative study, then I would say, sure, likely this is just an underpowered trial and there is a role. But here, there wasn't the same magnitude of benefit in PFS as one would expect and one has seen through Cleopatra. So I think that's the reason.
Question, of course, survival is more important, again, so without the PFS. Secondly, it's interesting, I wonder how long they got the capecitabine for. Was it continued through the whole thing? Because obviously in Cleopatra, patients stopped after 6 or 8 cycles, so I wonder. But anyway, survival's so important, and pertuzumab certainly it brings in a level of important non-cross-resistant therapy to patients who have had trastuzumab. So at any rate, as somebody who makes sure that everybody gets a line of pertuzumab today, at least in the U.S., I think the data sort of support that therapy.
I think one day we're going to have a CAPE backbone HER2 doublet. We have lapatinib CAPE. I mean, I think this would justify for someone who's pertuzumab naive utilizing it. It's an equivalent study, not a negative study. I'm trying to be positive here this morning. Equivalence. So
only this morning.
Yeah, right. I mean the bottom. Yeah, for just this morning. But I think, and then we have other drugs. Adam might be getting to them, but we have other small molecule inhibitors that are being studied in combination with capecitabine. We have a HER2 specific, this ONT-380, the oncotherian drug. So one day, especially because of CAPE's activity in the brain, I think we're going to get an ideal CAPE backbone combination.
That's a great, this is perfect. Thank you, Kim.